Hello, everyone. Thank you for joining our webinar today on Can Clinical Care Be Recovery-Oriented, which is the third session of the Principles and Practices of Recovery-Oriented Care series. Larry will be leading this webinar, and I'll be turning things over to him shortly. But first, I'd like to review a few items with you all. During the presentation, if you have any technical difficulties or questions about the topic, you can use the chat and questions box down on the bottom left. This webinar is being recorded and will be available for viewing tomorrow on our website, along with the PowerPoint slides and any additional resources discussed today. Information about CEUs and certificates will be sent in a post-webinar email. At the end of the webinar, an evaluation will pop up on your screen regarding this session today. Please take a moment to fill out, if you can, so we can continue to improve our trainings. We do have the fourth session coming up in March. If you'd like to register, you can visit our Eventbrite page. And if you would like to contact the New England MHTTC, you can either visit our website or email us at newengland@mhtttcnetwork.org. And with that, I will hand it off to Larry.
Thank you, Vanessa. Good morning or good afternoon, depending on how far west you're linking in from. And for those of you who have been in the first one or two sessions of this series, welcome back. If you're new to the series, welcome. My name is Larry Davidson. I'm a professor of psychiatry at Yale University, where I run the program for recovery and community health, and also happen to be the director for the New England MHTTC, and have spent my life's work trying to understand the notion of recovery and its implications for recovery-oriented practice, clinical and otherwise. And the spoiler is that yes, the answer to the question, can clinical care be recovery-oriented? The answer to that is yes, and we will spend the next hour together sort of discussing, well, not discussing, because I know that this is not a very interactive format, but because it's not interactive, please type in questions or comments that you have as we go. If we have many comments and questions, which I hope we do, and we aren't able to get to them all today, then we could start the fourth and last session of this series addressing questions and comments that come through for today's talk. And similarly, if you had questions or comments about the first two that you didn't have a chance to express or convey, please feel free to do that today as well, and we will start, if we need to, start our fourth session addressing those questions and concerns. But I'm going to start with questions and concerns also, and these are questions and concerns that have come up around the notion of recovery and its implications for recovery-oriented clinical practice. And I want to start there because these are the things that I've been struggling with over the last 20 years as we've tried as a field to grapple with all of the implications that come from this new notion of recovery. First of all, we've been engaged in this process not just since late 1980s, early 1990s, when Pat Deegan and Bill Anthony and others were starting to define recovery, but we've actually been on this path at least since the 1970s under the Carter administration, which inaugurated a community support movement in mental health. This was in the waning days of deinstitutionalization on a large scale, and the idea was that people needed to be able to live in the communities of their choice, and in order to do that, they needed more support than just the Thorazine and psychotherapy they might have received if they were lucky in the state hospitals. So we've been engaged in this community support movement of trying to support people in the community since the 70s. We've known about in practice psychiatric rehabilitation as part of that. We've had assertive community treatment teams and other intensive community-based services that served as alternatives to the hospitals. And more recently, since the 80s and 90s, we've begun to value and promote self-help, mutual support, and peer-delivered services. So a lot of this is sort of old news now. We also agree with most of the reports that have come out since the Surgeon General's report in '99 saying that mental health services need to be reoriented to promoting resilience and recovery, that mental health services need to be person and family driven, that hope, valued social roles, and a life in the community are to be desired and supported for people with mental illnesses, and that despair, discrimination, and a life in institutional settings are not desired, and we need to do our best to battle against them. So what's left? What's left, I'm afraid, is a lot of work. And that lot of work that I see from where I work in a medical setting is translating our emerging understanding of the nature of recovery, because our understanding of recovery is still emerging, and translating that emerging understanding into its concrete implications for everyday clinical and rehabilitative practice. Much more work has been done around the rehabilitative practice than around the clinical practice. And I would like to suggest that this process is just beginning and that nobody's fully figured it out yet. In other words, you don't just continue to do clinical work in the way you used to do, but embrace recovery as an outcome and think you're done. But we have a lot of work to do in figuring out how to provide clinical care in a recovery-oriented way, and this presents an opportunity for leadership in the field. So join us in this struggle. What's so complicated about this? Well, recovery doesn't just mean recovery. It doesn't mean getting better or being cured of a mental illness. That's what it used to mean, and we used to think that nobody would be able to recover, but that's not the case. We know that now. Over many years of longitudinal studies and life experience, we realize that many people do recover over time and recover fully. But being in recovery is different from recovering fully. Being in recovery and with a mental illness is a new concept which is not at all clear or well articulated yet. There have been over 150 definitions of it in the literature and thousands of articles published, but there's still no consensus on what being in recovery with a mental illness really means and how it changes our practice. Because the things you do to minimize the illness are not the same as the things you do to maximize the person's opportunities for a meaningful life. We know how to minimize the illness. What we have yet to figure out is how to maximize people's opportunities for living a meaningful life in the face of an ongoing illness. And as I'm going to point out shortly, recovery-oriented care requires a fundamentally different role for the person with the illness or the disability. This may be the most profound shift in our practice, is recognizing that the person's role is first and foremost, it's fundamental, and that our role is secondary to that, and to play a supportive role, which I'll describe. What does it mean? It means that recovery no longer refers solely to cure, the reduction of symptoms, or the acquisition of insight and skills, but also living a full life. So being a mental patient in recovery is not what we're looking for. We're looking for being a person in recovery who does lots of other things besides be in recovery and has a full and meaningful life. So as a mother, as an actor, as a musician, as an engineer, as an architect, as a plumber, as a whatever desires that person has to have a meaningful and fulfilling life, and is enmeshed and supportive in meaningful relationships. It further means that what keeps people with mental illnesses from living full lives in the community is not so much the illness itself, because there have been and there are many people who have figured out how to live full lives with the illness, as the ways in which they have been viewed and treated as other than the normal people and citizens that they are. In other words, as mental patients. This has been one of the important and lasting legacies of the consumer survivor and mental health consumer survivor movement, is recognizing that it's not just a matter of living with a mental illness, but it's a matter of living with the stigma and discrimination that has accrued to mental illness over the last centuries. And that is a challenge not just for the person with the mental illness and their family or loved ones, but it's a challenge for clinical and other practitioners as well. We have to focus just as much on helping people overcome the stigma and discrimination they experience on a daily basis as we do overcoming the challenges inherent to living with a mental illness. And that expands the role of the clinical practitioner to some degree. Recovery in this sense refers to what the person with a mental illness does to manage his or her illness while in ongoing pursuit of his or her own dreams and life goals. while establishing or reestablishing a safe, dignified, and meaningful life in the communities of their choice, and while continuing to suffer the effects of having a mental illness. If to some of you, perhaps younger people participating in this webinar, might start thinking that this all is a downer, and this is why am I emphasizing so much that people still have illnesses? It's because those are the people for whom recovery-oriented clinical care is the most important, and those for whom the recovery-oriented clinical care or clinical care needs to change the most to be recovery-oriented. Finally, it's the focus because it's people who learn how to live with the effects of having a mental illness are the ones who are more likely to recover fully over time. In other words, the more you're able to live a meaningful, and I'll emphasize this again later, there's going to be a lot of repetition in this presentation because I want to drive these points home. To the degree to which a person figures out how to live a full and meaningful life in the presence of a mental illness, that mental illness becomes a smaller and smaller and smaller part of their lives until in many cases it disappears altogether. But it's not something that can be done necessarily in a direct or more aggressive way. It takes time, and that's going to be one of the underlying themes for today's conversation or presentation is that this kind of recovery takes time. So we cannot do recovery, we as practitioners. Recovery is what the person with the mental illness does. It shifts our role from being the lead player in the dyad, in other words, to playing a secondary role. It's an important role, and it's one I value highly, but it's a secondary role in supporting the person's efforts to be in recovery. So what healthcare practitioners can do is offer recovery-oriented care, which supports the person's own efforts toward his or her recovery and enhances the person's access to opportunities to pursue his or her own hopes, dreams, and aspirations. I many years ago, gave a day-long workshop on trying to define recovery-oriented care for the state of Connecticut's mental health system, which we've spent many years doing this. And at the end of a very long day, one of the agency directors of a mental health center said something basically like, okay, Larry, it's all good and well. It's been a lot of flowery prose, but, what if the person won't cooperate with their recovery? Meaning that this person had substituted the notion of recovery, living with a mental illness in recovery, with the notion of cure, and was complaining that the person wasn't doing the right things in order to get over having a mental illness, and referring to recovery as that process. The recovery that we want to support is the person's own efforts to have access to and to make use of opportunities to pursue their hopes, dreams, and aspirations in the process of managing a mental illness. It's not another word for treatment compliance or treatment adherence. Isn't this just semantics? Why am I belaboring this point for 10 minutes? It's not just semantics. It makes a significant difference to understand that we have conventionally treated illnesses and rehabilitated patients and clients. We've conventionally seen our role as very active and interventionist. But people with serious mental illnesses want lives and all that goes with that. They don't just want treatment for their illness or rehabilitation for their skill deficits. They want a life and all that goes with that life. And as far as I know, in the United States, they are entitled to it by law. And this is not just a truism, this is an important point. What are they entitled to? What rights need to be restored? I was giving grand rounds at a medical school, again, maybe 15 years ago, and I say these things because these are long-standing issues in the field. But I was giving a grand rounds at a medical school about 15 years ago talking about people's rights and discrimination that people have suffered and how we need to restore the rights to people with serious mental illnesses. And a young physician stood up and said, what rights have people been denied due to them having a mental illness? Thinking that the only rights could have been coercion or keeping people in institutional settings. So once people are out of hospitals, what rights could they possibly have been denied? And I'm just going to mention two, but there's a long list of these. But the two most obvious to me are, first of all, social inclusion. People with mental illnesses are entitled to a life in the community. We could all agree to that, but they're entitled to it first as a foundation for recovery, not as a reward for recovery. In the past, we viewed living a full life in the community as a reward for recovering. We need to understand now that it's really more of a foundation for living that life rather than a reward. For example, just one example, is housing or a home. It's very hard to recover if you don't have a place to live. Housing cannot be contingent on compliance or improvement in a person's condition. Housing is basically a human right in the United States. Even though homelessness continues to be a problem, I think all of us could agree that people need a home, a sense of home, and they need a sense of home if they're going to recover, not after they recover. So making housing contingent on treatment is not honoring their rights to social inclusion. Another example is employment. There's a lot of employment discrimination against people with serious mental illnesses. Just try to help one of your clients get a job, and you'll run into it fairly quickly. The employment rate among persons with serious mental illnesses in this country is about 15%. Now, you may think that that's because a lot of people with mental illnesses don't want to work, which would be part of the stereotype. But in fact, when surveyed, consistently, about 70% of people surveyed with serious mental illnesses say that they would like to work. So if 70% would like to work and only 15% are working, why is there a gap? And one reason there seems to be a gap is, well, first of all, we don't have enough supported employment programs. There's not enough funding available. But put that aside for the moment. If you look into why clinicians are not referring their clients to supported employment programs, one important consideration in the past has been the perception that working is stressful. Working is stressful for people with some mental illnesses some of the time, and don't rock the boat if the person's stable and doing well by encouraging them to go back to work because it'll make them sicker. What that perception misses is that being out of work and poor is sure to be stressful for most people with most mental illnesses most of the time. This is a point that was made by Joe Maroney many years ago. He said, if you think work is stressful, try being unemployed. And I think it's a good argument for why we need to make better and more sustained efforts to help people get jobs. And the right to self-determination, which is the most important for today's topic. People with mental illnesses retain the right to make their own decisions, both in life and, yes, in treatment, unless, until, and only for as long as there are compelling reasons for society to interfere with their sovereignty. So unless there's serious imminent risk to self or others or grave disability, people with mental illnesses retain the right to make their own choices, which means, and this might be reassuring to some, that psychiatry is a form of health care. And psychiatry practiced in a recovery-oriented framework looks a lot more like health care than what psychiatry has looked like in the past. It means that as in all other non-emergency healthcare settings, people reserve the right to be free from coercion and have all care provided only with their informed consent, even when they still have symptoms or deficits, just like in other forms of healthcare. Nobody gives patients IQ tests before they make their own decisions about cardiac issues or diabetes issues or what to do with their broken knee. We just assume people are competent to participate in shared decision making unless we have reasons to think otherwise. The same should be true in psychiatry. Doesn't that increase risk, you ask? How can we empower, because a lot of what this first part of today's talk is about is empowerment. How can we empower people with serious mental illnesses to make their own decisions without increasing risk? Well, we still maintain the right in emergency situations we still have the right and societal obligation to intervene to protect the person and the community from imminent risk. That is still incumbent on mental health professionals. However, in all other situations, competent risk assessment and management, which I would argue are crucial components of a recovery-oriented system of care, crucial components of recovery-oriented clinical practice. Outside of those situations that are determined to pose serious imminent risk, people should be afforded what Pat Deegan has so eloquently called the dignity of risk and the right to fail. Those are equally crucial components of a recovery-oriented system. People learn by making mistakes. We can't protect people from making mistakes throughout their lives. They need what she has aptly called the dignity to take that risk to fail, and the right to fail and learn from your mistakes. Best example of this for me, coming again from Pat Deegan, was when she complained about having been assigned a case manager to make her decisions for her early in her recovery. And when she protested and said she was quite capable of making her own decisions, that she didn't need a case manager to make decisions for her, she was told that she wasn't capable of making her own decisions because she had failed in the past. She wasn't learning from her mistakes, and that was due to her mental illness. And that happened right around the same time that Elizabeth Taylor was launching her ninth wedding. So her retort was, well, why hasn't anybody assigned Elizabeth Taylor a case manager when she clearly doesn't learn from her mistakes either? This doesn't increase risk. Enabling people, empowering people to make their own decisions doesn't increase risk, because while some people with some serious mental illnesses pose some risks some of the time, most people with most serious mental illnesses pose no risks most of the time, and also make no worse decisions than people who have mental illnesses. Now think about that. There have been studies done that shows that people with serious mental illnesses make no worse decisions in their lives than people without mental illnesses. I don't know if that surprises you or not. If you're my age, it probably surprises you, because when we were in training, having a mental illness was synonymous with poor choices, poor judgment. Poor judgment was even one of the diagnostic criteria for having a serious mental illness. But in reality, most people with most serious mental illnesses pose no risks most of the time and make no worse decisions than anybody else. Just think about the decisions we make on a day-to-day basis and the degree to which those pose risks. So I know when I go to McDonald's, Burger King, or Kentucky Fried Chicken, or Popeyes, I get to decide what I'm going to eat. That's a decision that I'm entitled to make as an adult in our society. How often are people with serious mental illnesses who are in intensive clinical or rehabilitative programs told what to eat by staff? Staff make those decisions. If you ask the staff why they make those decisions, they will look at you like it's a funny question, and they're not in any way questioning the competence of their clients. That's just the way they do things. But we could look at that in lots of ways, at the way clinical care is currently provided, and to what degree are people offered the opportunity to make decisions about important things that are important on a day-to-day basis, not just on a life trajectory basis. As a result of this, healthcare becomes a collaborative enterprise. In recovery-oriented care, it's neither that the doctor is the sole expert, but nor is it solely self-help. It's a partnership. My wife is a nurse practitioner and has taught me a lot about recovery-oriented care through her explanations of how midwifery differs from surgery. It's more like midwifery than surgery. It's more a facilitative, consultative role than a mandated, coercive, aggressive, even if it's in the patient's best interest kind of approach. But for me, it's been captured best in the motto of Home Depot, which is, you can do it, we can help. You can do this recovery thing, and we can help you. We have resources, we have knowledge, we have supports to provide, we have things that can help, but it's up to you to do it, and you can do it. You have the capacity to do it. peer staff, just as an aside, which was the topic of our last presentation discussion. Peer staff are exceptional in their ability to be role models of this very notion that you can do it, because they're doing it. They're doing it in practice, in real life. And that sends a very important message to the folks they work with. So all of this is a way to say that first and foremost, recovery-oriented clinical practice is healthcare, and it's healthcare in which there is an active, essential role for the client, patient to play, and that they have rights to make choices in their own lives and to enter into shared decision-making processes with their clinical professionals as they become more and more capable of taking over those decisions. Now, on to suggested principles, strategies, and standards for incorporating the recovery paradigm into clinical practice. So we know clinical practice is going to be collaborative. It's going to involve shared decision-making and in the end, being respectful and honoring the person's right to make their own choices unless they pose serious imminent risk, and to learn from their mistakes. What else is it? How else can we understand it? And first, we're going to talk about what it's not. Recovery does not refer to what happens after cure, treatment, or care. So it's not something that we wait until later to talk about. It's something that starts when you first meet the person. How are they doing in their recovery? What do they need to do to embrace their recovery? What steps can they take in their recovery? It's not what happens later. It doesn't refer to a person's participation in care, treatment, or rehabilitation, like my colleague from many years ago who thought this person wasn't cooperating with her own recovery because she wasn't participating actively in treatment. Recovery doesn't mean you're doing what the doctor or the clinician tells you. It doesn't mean that you're making use of services. All of that can be well and good and in your own interest, but it doesn't refer, that's not what recovery refers to. Making use of treatment, yes, but just being in treatment, no. Recovery doesn't refer to add-ons to existing systems of care. I've heard many times from system administrators that they're doing recovery because they now have peer support, or they're doing recovery because they now have supported employment. And as important as supported employment and peer support and other rehabilitative practices are in supporting recovery, they are not recovery in and of themselves. We cannot do recovery. We can offer recovery-oriented services and supports, but we do not do recovery. And doing recovery is not something that's limited to peer supporters. Supporting the person's efforts toward recovery is not something limited to peer supporters. Now, more positively. So what is recovery-oriented care? Recovery-oriented care, and this is a definition that we developed in Connecticut around 2002, and it has withstood the test of time. So I offer it humbly for your consideration now. Recovery-oriented care is care that identifies and builds upon each person's assets, strengths, and areas of health and competence. So it's strength-based and builds on existing resources to support the person's efforts in managing his or her condition while establishing or regaining a whole life and a meaningful sense of belonging in and to the broader community. And recall the Home Depot motto: recovery is something you can do. Recovery-oriented care is something we offer to help you in doing it, to support you in doing it. Principle 5, unless you have clear and convincing reasons for thinking otherwise, you should assume that people with serious mental illnesses want the same things from their health care and their lives that you want for yourself and your loved ones. When you go to a medical care appointment, you want to be respected. You want the person, the clinician, to take an interest in you and know that you're not just a patient with a heart disease or a patient with diabetes. You're not a diabetic, but you're a person who has a life, which is the context in which you need to be able to manage your diabetes or your heart disease. People with serious mental illnesses want the same thing. They want respect. They want education and information. They want to be told, offered information about what we think is going on with them, for them. And they want the freedom to choose among the various options, those services or interventions which will be most likely to be helpful and least likely to be harmful. They need to understand what the side effects potentially could be of the treatments we're offering, and they need to be able to make choices about which side effects are worth tolerating and which are not, based on which effects treatments help to bring about and those they do not. Just adopting Principle 5 in and of itself would have a transformative effect on clinical practice in psychiatry. But there's also Principle 6, which makes Principle 5 sometimes difficult to adhere to. Neither recovery nor recovery-oriented care follow a conventional linear progression. This has been one of the hardest aspects about the process of recovery to convey to folks new to the idea, is that it's not linear. You don't reduce symptoms, acquire skills, and then live a full life in the community. That would be nice if it were that simple. And maybe in some cases with early intervention for people with early intervention for people who are new to having a psychotic disorder, first episode psychosis care. Maybe it's, in some cases this is now true in ways that it wouldn't have been true years ago, because people who are young and who are just new to the system, when provided recovery-oriented care early in the course of an illness, maybe they don't need the same time frame and the same struggles. Maybe they don't have to face the same struggles or need the same time frame as people who developed an illness longer ago and have had more of a legacy of discrimination and stigma. So maybe it might look more linear in the future, but we don't know that, and it's certainly not linear now. In fact, if there's a progression, it's more likely the reverse of what we expected when we thought it was linear. It could be that having a sense of social agency and citizenship might be a necessary foundation for having a sense of belonging and feeling capable of being reciprocal. Let me start over. It may be that having a sense of hope, having a sense of a positive self-worth, and having a sense of belonging and reciprocity, and having a sense of social agency and citizenship predate, in some ways, come before being able to make active and constructive use of treatment. People's citizenship should not be forestalled until they adhere to treatment and get better, because having a sense of social agency and citizenship can be a necessary precondition for being able to make active use of treatment. I think that's all for the principles. Yes. So why am I asking if clinical practice can be recovery-oriented? Where did that question even come from? It comes from many years of hearing back from practitioners that recovery is what rehab providers do, or recovery is what the person does, which in some ways we agree with, but in other ways it basically says it has nothing to do with me. They say things like, well, recovery is what happens in the community, not in my hospital or not in my clinic. Here we provide clinical care. People are too acutely ill to talk about recovery in the hospital. So why would you bother to try to introduce recovery into a hospital? Recovery doesn't become relevant until after treatment is effective, which is the notion I was just trying to dispel a minute ago. If somebody's willing to adhere to treatment, then we could talk about recovery. Recovery services are provided by people with less professional training than clinicians, for example, peer staff. Clinicians are only trained and paid to treat illnesses. These are all perceptions that we've had to struggle with in the field for the last 20 years. That's why the question, and that's why the webinar for today. My brief responses to these objections I've heard in the past are that recovery may happen wherever a person happens to be at the moment. You don't have to be in a rehab program, in a day hospital, in a social club, in a job, in a home to recover. But recovery can happen on an inpatient unit as well, if recovery means taking steps toward having a fuller life. Recovery doesn't come about only through people talking about recovery. So it's not as if what you do to promote recovery is talk about recovery. There's lots of things you can do to promote recovery without even using the term like making sure people have a home, making sure that people have meaningful opportunities to contribute to society, making sure people can pursue their passions and aspirations. Recovery also can happen inside or outside of treatment, and as I mentioned a few minutes ago, can provide a foundation for treatment to be effective. People who are in recovery make much more effective use of treatment than people who are not in recovery. But we can't force them to be in recovery by forcing them to be in treatment. Recovery happens in their daily lives, not just inside or outside of treatment. Or not just inside of treatment. Everyone who provides care, services, and/or supports should be promoting recovery. It's the aim of all mental health care. It's not just the responsibility of the peer staff or the rehab staff. It should equally be the responsibility of clinical providers to ensure that the care they're providing promotes recovery and does no harm. But what can you do, you ask, when a person is acutely psychotic and not making sense? Or what can you do when a person is posing a serious imminent risk to self or others? What can you do when a person is so depressed that he or she will not get out of bed, will not participate in anything, will not talk? What can you do when a person is demonstrating poor judgment and not learning from their mistakes, the way Pat Egan was described early in her treatment and recovery? And I'm sure you have other examples as well. I've seen at least one comment/question posed around this very issue of, well, but what can you do when the person is this, the person is that, the person's too sick? What can you do then? And I'm going to spend the rest of this time, the next 23 minutes or so, talking about the role of the clinical provider in circumstances when these things are happening. And I want to use as an example of this a descriptive passage from Ellen Sacks's autobiography, which was published in 2007. If you don't know of Ellen Sacks, she's worth looking into. She's a professor, a law professor at University of Southern California, and I think she's an associate dean now of the law school. She got her law degree from Yale University many years ago, but she also has struggled with schizophrenia since she was about 8 years old. And she describes the early signs and symptoms of the schizophrenia that she developed and their disabling effects on her when she wrote this. And then something odd happens. My awareness instantly grows fuzzy or wobbly. I think I'm dissolving. I feel my mind feels like a sandcastle with all the sand sliding away in the receding surf. This experience is much harder and weirder to describe than extreme fear or terror. Explaining what I've come to call disorganization is a different challenge altogether. In these cases, consciousness gradually loses its coherence. One center gives way. The center cannot hold. The me becomes a haze, and the solid center from which one experiences reality breaks up like a bad radio signal. There's no longer a sturdy vantage point from which to look out, take things in, assess what's happening. No core holds things together, providing the lens through which to see the world, to make judgments and comprehend risk. Random moments of time follow one another. Sight, sounds, thoughts, and feelings don't go together. No organizing principle takes successive moments in time and puts them together in a coherent way from which sense can be made. And it's all taking place in slow motion. This is one of the best descriptions I've seen of what it's like to have a serious mental illness, and one of the causes of the kind of difficulties we see in people who might be considered incapable of recovery or not ready for recovery or too stubborn to be in recovery or not having enough insight to be in recovery, all on and on. It's first important to stop and pause and consider what their experiences have been like that have really necessitated the situation that they find themselves in or brought it about. If I can't direct my own attention, which is what Ellen Sacks was talking about, if I no longer experience my actions as stemming from me, if I can't hold thoughts together or remember from one minute to the next, if even my thoughts seem to come from someone or somewhere else, she didn't describe hallucinations in that description, but you could add to that a loss of self that comes about through having hallucinations, that hearing voices that other people don't hear. And if on top of that, if other people act as if I'm not here, if other people do things to me without my permission or consent, if other people make decisions for me and about me without asking me, if other people tell me I'll never get better, if other people act as if I have nothing to offer, if other people no longer treat me as a person, then the person loses a sense of being a person to begin with. And that's where we have to start. Where we start in recovery-oriented clinical practice with people who seem very disabled by their serious mental illness to the point where they seem incapable of recovery or not ready to even consider recovery, is helping them to reclaim their personhood. Pat, again, put it most eloquently, which she said, once a person comes to believe that he or she is an illness, there is no one left inside to take a stand toward the illness. Once you and the illness become one, then there is no one left inside of you to take on the work of recovering, of healing, of rebuilding the life you want to live. In those cases that we're describing in which there is severe disability, the disability is both caused by and exacerbates the person's sense of being a person. And what we don't want is for our treatment to add to that, to exacerbate the sense of loss of personhood that the person has suffered. How does that change clinical practice? Well, first we have to step back and consider that many of our existing clinical treatments presume either that the person has to be restored to personhood by others before taking steps toward recovery him or herself, and that's the justification for involuntary treatment, is we have to restore this person to personhood before we can engage them in any other parts of a process we would call recovery, or the person has continuously remained a person and can take responsibility for his or her self-care and rehabilitation. So we assume we don't see the loss of self that has come about through the illness, and we assume the person is ready, willing, and able to take on self-care. And both assumptions, in the cases that we're talking about, both of these assumptions are problematic. In both cases, we miss the point that it may be our job as a clinical practitioner to help the person become a person again. Cognitive behavioral psychotherapy assumes a collaborative relationship with the client, assumes that the person can participate in a collaborative relationship. Medication adherence requires a person to take responsibility for self-care. Even if it's administered by others, the person still has to agree to take the medication. And that means that they're responsible for self-care. Cognitive mediation involves a working alliance. I'm not going to participate in cognitive mediation unless I think I can benefit from it, in which case I still think there's an I who can benefit. And similarly, psychiatric rehabilitation requires a minimum amount of confidence in one's own agency and efficacy. If I know that I'm a person, but I don't think that I can do anything, I'm likely to participate in rehabilitation efforts. If I don't have a sense of agency, a sense of confidence, a sense of efficacy, why bother? It's what Pat Corrigan, a good friend of mine and recovery proponent, calls the why bother syndrome. If I don't believe anything's going to come of it, why would I bother to try? But how do you help a person relearn that they are a person? Or how do you help them relearn to be a person? First and foremost, by treating them as if they are one already and always have been. This is the premise, the take-home message from this webinar, is first and foremost, we need to treat people as if they are people already. They always have been and they always will be, and they're deserving of dignity and respect, which means not perpetuating culture and practices which contributed to their losing their sense of being a person to begin with. In the late 90s, early 2000s, when the Dodd-Lieberman Act was instituted, we had to come to grips with the fact that restraint and seclusion could only be used as emergency measures. They could not be used as behavioral interventions, and there was a lot of skepticism in the field at the time that was not going to be possible. You could not run a psychiatric hospital, for example, without being able to use restraint and seclusion as behavioral interventions. And a lot of research was done around restraint and seclusion use. And one of the, at the time, surprising things that came out of it was that people were not always opposed to being restrained. They were opposed to the ways in which they were put in restraints, and the fact that nobody had the wherewithal to involve them in the process and to even explain what was happening. So there will be times, hopefully few and far between, but there may be times when we have to make decisions for people because they've lost the capacity to do so. Or we may do things to people that they don't want, or we may have to do things to them without asking for their permission. There may be times. But even in those times, we can explain what's going on and we can offer them some options from which to choose. I will not go into this long story about a friend of mine in New Haven who was a patient at the mental health center that I used to be the clinical director of, and who was gravely disabled. She has cocaine addiction and schizophrenia and was not doing well. She'd lost 30 pounds, and people were concerned that she was gravely disabled and that she needed to be in a hospital. And she said she wouldn't go to a hospital unless I talked to her first. So I went down to the acute services area and talked to her and told her she was going to the hospital. It wasn't my choice. It wasn't her choice, but her clinical staff had determined that she would die if she didn't. But she had a choice in how she went to the hospital. She and I could get up and walk together across the street, and she could be hospitalized with her dignity intact, or she could get tied down to a stretcher and taken through the tunnel under the street and admitted involuntarily and in less than ideal circumstances. And she appreciated the fact that I'd offered her a choice, even though I had told her that she didn't have a choice about being in the hospital. She had a choice about how she would go to the hospital. It's a terrible example, I know, because it's so severe in its implications. But I do want to recognize that even when people are at their most disabled, they still could be afforded choices, and they still need to have at least be told what's happening or explain to them what's happening, even if it may seem as if they're not going to take it in. And then, more positively, by noticing the decisions people are making and how those decisions are indicators of their remaining personhood. I was consulting to a residential program many years ago, and the staff were complaining that the residents wouldn't get up at 7 o'clock for their morning medications, and they insisted on being able to sleep in. And I asked them what was so terrible about that. They weren't in the hospital anymore. They weren't patients. They were living in their own apartments. Maybe the fact that they were sleeping in was because actually we asked the patients, I asked the patients, the residents, about this. And what they said was basically, we're not in the hospital anymore. We're in our own apartments, and we haven't been able to have a lie-in in many years. They enjoyed luxuriating in the fact that they could close a door and have privacy and be in a bed, a comfortable bed. So the decision not to get up for their medication could be taken as in non-compliance or being uncooperative, or it could be taken as a sign of people liking to lie in bed and luxuriate when they hadn't been in one for so long, in which they had privacy. By finding out where their remaining passion or interests, their sense of meaning or purpose, and their pleasures have survived, what are they still interested in? One of the early lessons I learned about recovery was from a young woman who had been hospitalized over 100 times for schizophrenia, but was doing much better. And when we asked her what she thought was the turning point, she said that it was when her nurse, she was in isolation and seclusion, and her nurse gave her a battery-operated radio so she could turn on the music and listen to the jazz that she loved. Turned out she'd been a Juilliard student before getting sick, and reconnecting to her passion of music and being able to be the one to decide what kind of music to listen to was the foundation for her efforts to recover. And by encouraging and supporting their sense of agency, even at the smallest of levels. People don't always sleep in the morning because they're luxuriating. They might sleep in the morning because they have the sense that there's nothing to get up for. There's no reason to get out of bed. So sometimes getting out of bed can be a first step in recovery. I'm getting out of bed because I have something to look forward to, something to enjoy, something that will give me pleasure or meaning in my life, not just taking my medication. And by reintroducing the person to themselves. This I've learned from the qualitative research we've done over the years. One person from, I believe, Sweden said, the whole story of my health was a very difficult experience because I had to really reconstruct myself as a person. I had to relearn how to be a person and what kind of person I was. And one of my favorite quotes comes from Amy Johnson, who's a woman in long-term recovery who I've worked with for many years, who once said, having schizophrenia means you must invite me to my own party because I don't know to bring myself. You must use nice language to describe this stranger who's coming to the party, me, make her sound like a nice person so that I'd like to meet her when she arrives. There's an increasing literature lately about how recovery is a relational concept. Recovery happens in relationships. And this quote from Amy, I think, really captures that best. We come to know who we are through the eyes of the other people in our lives, through the eyes of the people we interact with. So how am I going to know who I am except if you help me to see myself through your eyes? And if those eyes are stigmatizing and discriminatory, all I see is a mental patient. I am a mental patient. But if through those eyes I see that I love music, then I'm a jazz aficionado. Or if I see through those eyes that I'm capable of getting a job, then I'm a potential employee. How I come to know myself is through my interactions with other people, which is why the clinical relationship can be so foundational for people who are very disabled, because they're not treated like people in other parts of their lives, because they're not acting like people, so to speak. We need to keep first and foremost in our minds that they are people who are doing their best to get along on a day-to-day basis, and it's our job to help them do that more broadly and more effectively. And to do this, going back to Pat Deegan's comment from before about no one left to take up the work of recovery, is another quote from Amy, who talks about the importance of separating the person from the effects of the illness in order to create that sense of personhood. I tried to think about why personhood is so important. You separate the forest from the trees. I can't always separate the forest from the trees. If I am my illness instead of I am a person who an illness happens to, then I can never get better, because I can't pull the illness off of me if I am the illness. If the illness and I are the same thing, then there ain't nothing I can do. I can't change me. I can't. The forest and the tree become the same thing. But if you separate the two, suddenly I find strength. I ask myself, where? Where do you find it? I find it in the separation. If we are not the same thing, if I am not the illness, then I can beat it, I can trick it, I can outmaneuver it. I can go to the library and read about how to navigate around it. If I'm not the illness, then the hope that I can maybe beat it springs forth. Hope then comes from splitting off the illness from the person. This is a preview of coming attractions, because what I'm going to talk about in the next and last webinar in the series is helping people to claim social roles other than mental patient. One of the things that's so important about community inclusion is that's how people come to find out who else they are other than someone who suffers from a mental illness. In the case of Betty, the young woman who I mentioned who loves jazz, she had been a jazz pianist, she was a jazz lover. That's who she was, in addition to having a mental illness. People are citizens in addition to being a person with mental illness, and they are entitled to the rights of citizenship and to explore their passions and aspirations, to have a life. So to do this, I'm going to have to stop in a minute. To do this, noticing and reinforcing that people's decisions are a reflection of who they are, we have to look at levels of functioning that we take for granted. People take for granted that you just do things. You just get out of bed in the morning. You just take care of your hygiene. You just put on clean clothes. You just do this. You just do that. But for a person with a serious mental illness, it's sometimes hard. It's like you're distracted, and you can't get involved because you're not sort of all there. Going back to Ellen Sachs's quote, if your sense of me is transitory, is compromised, is at a distance, then it's not so easy to take for granted doing things like putting on clean clothes or taking care of your hygiene or making what other people think would be the natural best decision for you. And it's when people are able to do these things and have someone else notice them that they are able to start moving outside of the limits of the illness. This is from a 2003 book called Living Outside Mental Illness, where I tried to argue that severe and refractory disability is a result of people getting stuck inside of the illness. And what they need to do is to be able to move increasingly outside of the illness. And they do that when they have a sense of acceptance and belonging and are invited out of the shadows by other people. Whereas on the left, in terms of being stuck inside, they experience severe social isolation and despair. There's no hope. I'm nobody. If I'm nobody, I do nothing. And if I do nothing, then I'm nobody. So to be somebody, I have to do things. And I'm not going to go through the rest of these slides because we're running out of time, but I do want to give one last story to exemplify this point. I had the privilege of working with a man with schizophrenia for about 10 years who I'll call Paul. Paul and I had what I think was a very good working relationship, and Paul did really well for a long time. And then so much so that Paul had a knack of letting me know when important things happened in his life. He would either call me if he was in distress, or he might email me good news about something, just to keep me apprised of his situation. And one day he called me very upset, and it was in the afternoon, and I picked up the phone and we talked for a few minutes. I asked him what he was upset about. He said that the residential staff in his supported apartment program were threatening to throw him out of the program, and which meant he would lose his apartment. And I asked him, why did they threaten to throw him out of that program? And he said, because I don't go to groups. And I asked him, why didn't he go to groups? And he said, well, today, or when this all came to a crisis, today the group was a self-esteem group. And I thought it was more important that I go to the college class I'm enrolled in at Albertus Magnus College than to go to a self-esteem group. How do we build self-esteem? Not just by talking about self-esteem, but by doing things like going to take college classes. People have to do things to promote their own recovery. They don't just have to have insight into having an illness. That only goes so far. But I think with that, I will start to wrap up because we're out of time. So I would encourage you, if you do have comments or quotes about this or either the first two webinars, that you put them in the chat box, and we will take them down, and maybe in our next webinar we may start with addressing some of those comments or questions that we didn't get to today. I apologize for not getting to it today, but after the first two webinars where I got through the material I had prepared in like a half an hour, and we had a half an hour left, I wanted to make sure today that I didn't run out of material and that I gave you a full hour, so I didn't get to all the slides. So if what I've said to you today is of interest, you can download the slides tomorrow, and you'll see that there's probably another 20 slides or so to go, fleshing out more of this notion of helping people establish a self outside of the illness. And I think with that, Vanessa, I think it's time to say goodbye and enjoy the rest of your day.
Hi, everyone. Thank you for joining us today on our webinar. And thank you, Larry, for discussing the webinar. It's been really great material. The recording of the webinar and the slides will be posted on our website, and information will be going out tomorrow to everyone. And if you do have any questions, we can always try to email the answers if you prefer. And yeah, thank you, everyone. If you could just remain in the room, and the evaluation should pop up on your screen. Thank you.